Good evening, everybody, and welcome to the JIA-at-NRAS Live on this very hot and sticky evening. So if you're joining us tonight, thank you very much for giving us your time. Tonight we're going to be talking about all things oral health and rheumatoid arthritis, and I'm joined tonight by my co-host, Maddy Roberts, and our expert for tonight, Professor Iain Chapple. And I'm just going to ask you guys if you would like to introduce yourselves. So Maddy, would you like to go first?
Yes, thank you, Elsa. Good evening, everyone. I'm Maddy Roberts, and I am the Families and Young People Services Manager. So I work with young people living with JIA as well as young people living with RA.
Thank you.
Iain, and great if you.
Yeah, Iain, over to you. Would you like to introduce yourself, please?
Sure. So my name is Iain Chapple. I'm a professor at the University of Birmingham and part of Birmingham's Biomedical Research Centre, where, believe it or not, we do quite a lot of research into inflammation and how it affects conditions such as rheumatoid arthritis, and what I'm going to be talking about this evening, which is essential oral health and oral disease and how it links to rheumatoid arthritis. But we also do a lot of work on the gut microbiome and gut inflammation and various other non-communicable inflammatory diseases.
These are such interesting areas, Iain, because I think there's a new focus, if you like, on things like the gut microbiome. And certainly when we had a chat a couple of weeks ago, you were talking about oral health being a sort of public health real issue in inflammatory diseases. So I'm really interested to hear your presentation tonight, as I'm sure everybody else is. So would you like to share your screen and let's get going with the presentation, and then afterwards we'll field you the questions that have been submitted prior to tonight's event.
Delighted. Can you see the screen? I'm hoping everybody can see the screen anyhow. So, well, thank you, Elsa, and thank you, Maddy. It's an absolute pleasure to be invited to speak to you all this evening. I guess my key message to end with is probably a good one to start with, and that is healthy gums don't bleed. So if you have bleeding gums, it means they're not healthy. It's not natural that happens. So this is a view from the top floor of Birmingham Dental Hospital, a view of the beautiful campus at the University of Birmingham. And next to the clock tower on the right, you can see the Queen Elizabeth Hospital in Birmingham. So I'm a strong advocate of putting the mouth back into the body. And that is a strapline I use a lot, because traditionally, I'm afraid the training of oral healthcare professionals, dental surgeons, dental hygienists, therapists, etc., has become separate from the training of physicians, almost to the extent that physicians disown the mouth and we as oral care professionals almost disown the rest of the body. And it really brought it home to me back in 2013, really, when a paper was produced. It was a letter actually written to the Royal Society of Medicine that described periodontitis as a disease that resulted from untreated dental caries, which is completely wrong. And this was from two very high profile professors of medicine at a very high profile university. So I felt compelled to write back in to explain the difference between these two diseases. That was picked up by the editor of the British Medical Journal at the time, who said, "Iain, will you do us an editorial? Because I know what the difference is, but clearly a lot of our profession don't." And I called that time to take periodontitis seriously. That was back in 2014. So let me just explain to you, and apologies for those of you who know this, what the difference is. So dental caries is basically tooth decay, and it is caused by sugar, fermentable carbohydrates that are fermented by bacteria that sit next to the tooth or on the tooth surface. And they create acid, and the acid creates holes in teeth. And that basically is what dental caries is. And you can see here in this image, somebody's got lots of dental caries or tooth decay. The gums are also inflamed. You'll see the margins of the gums are slightly red, but this patient does not actually have periodontitis. They have tooth decay or dental caries. And these x-rays, the one on the left with the two blue circles, so I hope it's on your left as well, that shows you where, I don't know if you can see my arrow, these little black spots here, and that's the tooth decay burrowing into the tooth. It's a very, very early stage of detection that is often reversible at this point. But if we move across to the other side of the screen, you can see the crowns of these teeth have been destroyed by the process. And it now starts to involve this black line running down the tooth. That's the root canal. And you end up with root canal infections, as you can see here, at the ends of the roots of those teeth. So that's what dental caries is. This patient, however, in the green circle, does also have periodontitis. And periodontitis is loss of bone that sort of surround the roots of the teeth. And the reason that develops, I'm going to come on to explain shortly, but it's a different disease to dental caries. And you can see more bone loss here, the dark shadowing of the bone. So periodontal disease as a general term encompasses a whole host of different conditions, but there are two main ones. One is gingivitis, which is very superficial inflammation of the gums that is entirely reversible. And the first sign of that is bleeding from the margin of the gum when we examine it with a special probe, or you might see blood in your saliva. Periodontitis is a deeper seated condition that destroys the bone. So they're quite different, but they are a continuum. Gingivitis leads to periodontitis. So this patient has periodontitis, and you can see the gums have receded here. There's more inflammation or redness around the margins and lots of plaque and mineralized plaque we call calculus or tartar is the common term for it. And this serves as it's a bit like a coral sponge. If it's not scraped off by a professional, it tends to trap the plaque bacteria, and they then cause and trigger this inflammation and make it worse. And, you know, this patient doesn't have the gum recession, but they still have periodontitis. You won't be able to see that yourselves, but I know as an expert looking at the color and the swelling here, that if I use a special probe, it'll disappear down here because the bone's being destroyed beneath. And this is the type of probe that we use, and that probe is sliding down to a distance of about 5 millimeters, and it should really only go down to 3 millimeters. It's a painless thing to do, but that's what most dentists and dental hygienists will do when they're screening for gum disease. This is what we call pristine health. This is perfection, and it only exists in textbooks. And this is a picture from one of my textbooks, and I had to examine 340 dental students to find one example of perfection in a 19-year-old student who was actually of Spanish origin. So it's very, very rare that this happens. Most of us have small amounts of inflammation, not significant, nothing to worry about, but pristine health is very rare. Believe it or not, this is also healthy. This is a patient who has had periodontitis. You can tell by all the recession that you see here. Excuse me. They also have some sort of surface caries or tooth decay, but nothing particularly significant or serious. But if we use a probe on this patient, it doesn't disappear for more than 3 millimeters. So this patient is maintaining stability in their periodontitis, and they're actually currently healthy. And the same thing is happening here. This looks horrendous. The roots of the tooth are exposed. The division of the roots that we call the furcation is exposed. But actually, when we probe around here, we get no bleeding, and the probe doesn't disappear beyond 3 millimeters. So this patient is maintaining their stability extremely well. It's a little bit, the best analogy would be like, I suppose, a situation where, you know, the DAS-28 score in rheumatoid arthritis is low and it appears to be under control. Or with diabetes, you can have a patient with diabetes, but in fact, they're controlling their glucose levels very well. So they're a well-controlled diabetes patient, and they don't get the complications developing if they control things well. And it's the same with periodontitis. And the final image here is an image of what may look like complete gum coverage here to you. And it makes the point there's not a lot of inflammation, a bit of a red band around the gum margin here. But if I now show you this patient's x-rays, the white line is where the bone should be, and the black space is where it's been destroyed. This is huge destruction. And without using our probe and without taking x-rays, we wouldn't really know that this was going on. It's almost to the ends of the roots. These teeth at the bottom, at the front, are almost falling out. So that's my first key message, really, is that dental caries and periodontal disease are different diseases, completely different. The other thing that people really are not very familiar with is the economic and the human cost or burden of oral diseases. And when I'm talking about oral diseases now, I'm talking about periodontitis and I'm talking about caries. I'm not talking about the hundreds of other oral diseases because they're quite rare by comparison. And actually, oral diseases, caries and periodontitis, are the most common diseases to affect human beings. And more years are lost to disability from those two diseases than any other of 364 human diseases. That's the Global Burden of Disease study published in The Lancet in 2017. So this is a big, big problem. And the cost is huge as well. As you can see there, $550 billion in 2015 were spent on managing, well, that was the cost of dental disease. And periodontitis, which is now going to become my focus for this talk, it affects about 40 to 50% of adults to some degree. Most of it is mild or moderate. The one we worry about is the severe disease, and that affects now 19% of adults, according to the WHO. It's increased in the last 30 years by 8.5%. And the reason for that is complex, but it relates to people deciding they want to keep their teeth for longer, and so they do. Therefore, there's more periodontal disease to manage because the teeth aren't extracted. Best way to treat oral disease is to take a tooth out. It's the worst thing you can do, but that's the quickest way to get rid of the disease. And so the other thing that's happening is we're living for longer, and therefore we're retaining our teeth for longer. The human cost, of course, is massive because periodontitis is the biggest cause of multiple tooth loss in an individual. So you lose teeth, it negatively impacts your speech, your nutrition, your sort of self-esteem and self-confidence, your quality of life, and your overall well-being. And actually, periodontitis is also an independent and significant risk factor for premature death from any cause or from cardiovascular diseases. And it's linked to many other non-communicable diseases, as Ailsa was alluding to, of the body, which I'll come on to explain in a moment. So literally a couple of months ago, The Economist published a white paper. They've published two now, one in 2021 and one this year. And this one was called Time to Put Your Money Where Your Mouth Is. And it was basically looking at levelling up oral health from those from lower socioeconomic backgrounds where we have a lot of health inequalities to those from the higher socioeconomic backgrounds. And this is data from that white paper, and it shows you here that 3.6 billion people suffer from periodontitis and dental caries, which is 1 billion more people than all of those other non-communicable diseases added together: cardiovascular disease, diabetes, cancer, etc. So it's a huge burden. And they also pointed out in this economic analysis that the global spend on oral diseases, the direct treatment costs, are almost 5% of global health expenditure. And then in addition to that, you've got what we call indirect costs, which is, time away from work, for example. And the most deprived are the most exposed. And when you look, for example, at low educational attainment, that's associated with an 86% increased risk of periodontitis and a 44% increased risk of dental caries. So like many diseases, these tend to focus in those who have the highest health inequalities and from the lowest socioeconomic backgrounds. This is the white paper The Economist published in 2021. This was focused on gum disease, and it was called Time to Take Gum Disease Seriously. And it basically modelled the economic savings for 6 major European countries that could be achieved by one of two things. If you were able to stop gingivitis developing, what would the return on investment be? In other words, for every euro or pound you spent trying to eliminate gingivitis, how much would come back into the economy of that country? And the other thing they looked at was diagnosing and treating 90% of periodontitis, because a lot of periodontitis is not diagnosed and treated. But if you could do that for 90%, what would the return on investment be? And the data was quite astonishing, really. If you could prevent gingivitis developing, you would save, over a 10-year period, 36 billion euros in Italy and almost 8 billion euros in the Netherlands. But perhaps more importantly, if you neglect managing gingivitis, if you ignore bleeding gums, then you will significantly increase health costs and you will reduce healthy life years. So the other thing that the economist talked about was better integration of medical and oral healthcare systems, and that is starting to happen, but it's only in the development stage, because there are common risk factors like smoking, for example, and high sugar intake, for example, and high stress levels for many of these non-communicable diseases. And if the oral care and the general medical care community start working together, then we can address these common risk factors and help each other out, if you like, as professions, and most importantly, help our patients and the public out. So we need to encourage better integration, and that is also starting to happen now. Because if all healthcare professionals start helping to manage risk factors for conditions like rheumatoid arthritis or cardiovascular disease, that's got to be beneficial. And similarly, if physicians start to try to detect gum disease early, that will also help in terms of managing that as a risk factor. So my second key message really is that all diseases are the most common of humans. They cost more than any other human disease, and they cause significant disability, and both social and mental problems result from that overall impact on a reduction in quality of life. When we look at the links between the mouth and the rest of the body, about 57, this is back in 2016, a systematic review looking at the number of associations that have been explored between periodontitis and other human diseases. And rheumatoid arthritis sits in this musculoskeletal category down here. The most of the work's been done on cardiometabolic diseases, cardiovascular disease, and on diabetes, where the associations are very, very strong. They're so strong that the International Diabetes Federation have published guidance on periodontal disease, and in fact, so have the World Heart Federation. And then literally last month, the Journal of General Medical Practitioners, Family Doctors, that's this paper here, has published this paper looking at periodontitis and its effect on cardiovascular disease, diabetes, and respiratory diseases. So why are these links there? And the answer lies in this question, really. What do these non-communicable diseases have in common? And most of you can probably answer this. They're all inflammatory diseases. They're all complex diseases. I'll explain what I mean by that in a minute. They're all associated with periodontitis, and they're all non-communicable diseases. What I mean by complex diseases is a complex disease, and rheumatoid arthritis is a complex disease, so is periodontitis, so is cardiovascular disease, so is type 2 diabetes. They don't have a single cause. They have multiple causes. There's a very famous epidemiologist, Rothman, who 20 years ago produced this sort of hypothesis that explains causality of complex diseases. And a lot of people sign up to this still today. Each one of these circles is called a pie, and it represents a patient with a disease. So sufficient cause 1 is patient number 1, patient number 2 is cause 2, etc. And in order for the disease to develop, in this case, we'll say it's periodontitis, in order for the disease to develop in patient 1, they have to have a full pie. And each slice represents a different component cause. So D might be smoking in patient 1. In patient 2, D isn't present. G might be high blood glucose levels, a high refined carbohydrate diet. In patient 3, I may represent high stress levels without coping behaviors. And A is present in every patient. It's a necessary component cause. And without it, you don't get the disease, but on its own, it's not sufficient to cause the disease. So this would be a buildup of dental plaque on the teeth, traditionally, or today, I would say that A is more likely to be inflammation. If you don't have inflammation in the gums, you will not have periodontitis or get it. And I'll come back to that in relation to rheumatoid arthritis in a minute. So there are a couple of hypotheses behind these associations, and the first hypothesis is called the common risk hypothesis. What that says is that periodontitis doesn't cause these other diseases. What happens is that patients who develop these diseases are either genetically or through their lifestyle or their behaviors exposed to producing too much inflammation. So they produce too much inflammation, and therefore their likelihood of developing rheumatoid arthritis or cardiovascular disease is increased coincidentally for all of these diseases. And there's quite a lot of evidence for that. The second hypothesis is one that I call comorbidity and cumulative damage. And to illustrate this to you, I'm going to talk about chronic kidney disease, because this is data from our group. Praveen Sharma is one of my team, and this was his data from his PhD. What this shows you on the vertical axis is survival of people with chronic kidney disease against, on the lower axis here, the horizontal one, the x-axis, time up to 15 years. And if you have chronic kidney disease, your mortality increases by 30% over 10 years from any cause and 16% mortality from cardiovascular disease. If you have periodontitis as a comorbidity, you get a further increase in 10-year all-cause mortality of nearly 10% and of cardiovascular mortality of 6%. And if I replace the red line, which is periodontitis, with diabetes as a comorbidity, they almost superimpose. So the impact of periodontitis, if you have chronic kidney disease, on your life expectancy is the same as diabetes. But sadly, most of these people are multimorbid. They have all three, and there are very few left alive at the end of that 15-year period. And there's quite a bit of evidence for this. So what does it look like? Well, this is a tooth sticking out through a gum, and the crown of the tooth is here, the root is down here, and the gum meets the tooth, and there's a natural space between the gum and the tooth that you can't see. That's where we put the probe. It's called a sulcus. And basically the tooth, unlike the skin, doesn't shed. So when bacteria build up on the skin sheds every few days to get rid of them. The tooth doesn't shed. So you've got to physically remove the bugs from the tooth by toothbrushing, and it's not easy, because the area you've got to focus on is right next to the gum margin here. And if that doesn't happen efficiently, those bacteria build up and they irritate the skin cells here, and they cause inflammation in the gums called gingivitis. If we remove the bugs, the gingivitis will resolve. But in patients who have that hyperinflammatory characteristic that are at serious risk of periodontitis, the inflammation becomes poorly controlled, it becomes excessive, and it destroys the bone around the teeth, and you get periodontitis. And I showed you this patient earlier on, and you saw the bone destruction. Compare that to, let me just put the next image up, to swollen joints, as you see here, and the bone destruction you get with rheumatoid arthritis. Very, very similar. And the key issues here I've highlighted in these blue boxes. When the gums become inflamed, little ulcers develop that you can't see between the gum and the tooth. The inflammation causes these ulcers to form. That's how the blood gets into your saliva when you have inflammation and brush your teeth. But the bacteria also get pumped into the bloodstream every time you eat, every time you speak, and go about your daily functions. So we know that in patients with periodontitis, they have this low-grade entry of bacteria into the bloodstream, and they travel all over the body and trigger consequences elsewhere. And they also activate white blood cells to cause inflammation in the bloodstream. This is at a very low level, but it happens over many years. We also know in this second blue box, the middle box, that the inflammation of the gums can spill over into the circulation and add to that burden. That's the comorbidity. But from the point of view of rheumatoid arthritis, it's a different mechanism that we think is linked. And it's something I call immunological memory. I'll explain what I mean, but basically the inflammation changes proteins structurally in the gums so that they start to attract antibodies. In other words, the body's immune system turns on those proteins, and the antibodies that are produced are the antibodies, the ACPAs, that cause rheumatoid arthritis. So my third key message here is that periodontitis shares risk factors with other non-communicable diseases. So last 5 minutes, really, let's focus on rheumatoid arthritis, because that's what we're here to talk about. Hippocrates, 400 years BC, was the first to make a link between oral disease, and we think periodontitis, and rheumatoid arthritis. And he claimed to have cured a patient's rheumatism by extracting an infected tooth. And this is a study from our group a number of years ago that shows that if you have rheumatoid arthritis, you're 227% more likely to have no teeth and be edentulous, and you're 182% more likely to have gum disease. And so I said there's a common risk factor hypothesis. When you look at these risk factors, you recognize some of these. These are the risk factors for periodontitis. The risk factors for rheumatoid arthritis are very similar. Smoking, there is a genetic component. We know that female sex hormones play a role. And we know that the inflammation responds to anti-inflammatory medications. And back in 2009, we were asked to write a review paper to try and explain this relationship. And this is the paper here in Nature Reviews Rheumatology. And we looked at both directions. Rheumatoid arthritis here is in the middle, periodontitis is on the right. It's possible that patients with rheumatoid arthritis develop periodontitis because of limitations in dexterity, and it makes it much harder, if you like, to remove the bacteria from the teeth when you brush your teeth. We also know that conditions like Sjogren's syndrome are associated with rheumatoid arthritis. Sometimes that dries the mouth up because your saliva flow dries up, and so the saliva doesn't wash the bacteria away. And then maybe there are treatment preferences here whereby patients get fed up with trying to save their teeth with the disease and they decide to have them taken out. And then there are drugs used for managing rheumatoid arthritis that can cause osteopenia and osteoporosis. Corticosteroids, for example, will do that, and that will mean the bone in the mouth is less dense and more likely to be lost. In the other direction, periodontitis could drive the development of rheumatoid arthritis, and one of the reasons are periodontal bacteria. There is one in particular called P. gingivalis, which some of you will have heard of. And what it does is it produces an enzyme that is able to change proteins and add an amino acid called citrulline. Doesn't matter what the amino acid is. The point is that when that happens, when proteins in your body carry that amino acid, they generate antibodies against themselves. And it's the ACPAs, the anti-citrullonated protein antibodies, that are developed. So this hypothesis says if you have gum disease, then you will have this P. gingivalis organism, and it will make these changes to the proteins in your gums that will lead to the production of antibodies against those proteins. And those antibodies can, at some point in the future, target the joint, and you can get JIA or undifferentiated arthritis, and then ultimately rheumatoid arthritis. And there is some evidence for this. So, fourth key message, periodontal bugs like this one can change proteins in your body and turn your immune system against those proteins. And then the penultimate one really is this beautiful cell here called a neutrophil. And what this middle image shows you is what these are neutrophils, the big round cells, the neutrophils, and it looks like they've got a load of cobwebs between them, doesn't it? We discovered not many years ago that when neutrophils are challenged by bacteria, 30% of those cells will die, but they don't go quietly. They release their DNA from their nucleus, and that's what the cobweb is. They release the nuclear DNA, and that release process requires massive citrullination of the proteins inside the nucleus. So this DNA that's released in response to bugs in the gums is releasing a lot of those proteins into the gum tissues. And so that citrullination process that generates those antibodies is also being caused by the neutrophil. And there's lots of evidence for that. So if that's the case, you would think that patients who have periodontitis and who do not have rheumatoid arthritis should have ACPAs in their bloodstream. And this is a paper we published 10 years ago now that shows you exactly that. These are non-rheumatoid arthritis patients, and the blue bars are the ACPAs in periodontitis patients, and the red bars are non-periodontitis patients. There's a massive difference. So the autoantibodies are there in periodontitis patients, even though they don't have rheumatoid arthritis. So these white blood cells, the neutrophils, are dominant in periodontitis. So my final few slides, because my time's up really, if these cobwebs, we call them nets, neutrophil extracellular traps, these cobweb structures released by the neutrophils are triggering these antibodies and the inflammation, you should be able to find these nets in the joint as well, because that's where the inflammation happens in rheumatoid arthritis. And this is a fluid sample from an inflamed joint. We've stained it blue for DNA. The blue blobs are the neutrophils, and you can see the cobwebby nets there. And we can use another pink stain to really light up these nets and show you that they are there. And my final images here, really, this is DNA in another joint, blue. We have to show those citrullonated proteins are there, and here they are in red. And when we bring those two images together, you get pink, and you can see that we've got these proteins, these altered proteins in the joint. So the current thinking is that in some patients, if you think of that complex disease model, maybe the periodontitis is a slice in the pie, only one slice in the pie, but nevertheless a slice in the pie for some, but not all patients who suffer from RA. And these bugs cause the citrullination, and the neutrophils cause the citrullination in the gums, and we know we get the antibodies produced because we can measure them in the blood. So that's my final key message, really. These nets, these neutrophil traps, are released in the gums. We've shown them and proved that that happens, and we also find them in the joints. They could be the link between the two conditions. So I'm going to conclude. My time's up. Tooth decay and periodontal disease are different diseases, quite distinct. All diseases are the most common of humans, and they have a huge cost to the economy, to human health and well-being. And periodontitis, deep-seated gum disease, does share common risk factors with other non-communicable diseases like rheumatoid arthritis. Some periodontal bacteria can change proteins in the gums that generate the rheumatoid arthritis antibodies, and so can these white blood cells, the neutrophils, that are dominant in the periodontal tissues. And finally, we also find those structures in the joints, in the inflamed joint. So I'll stop there with an image. And this is something we produced a few years ago to raise public awareness. It's obviously a model, we have a male version, but this is the impact that gum disease has psychologically on an individual when they get it. It's not very nice, and it does have a huge impact on people's well-being and on their sort of quality of life. So thank you for listening. I think, Ailsa, it's probably time for me to stop, and we have lots of questions, I think, to answer.
We do. Thank you so much, Iain. My goodness me, that was absolutely fascinating, but also, I'm sure Maddy will agree, rather scary. But I've always said knowledge is power, and if you know about this stuff, then you can take action and you can do something, and that's so important. So I'm so glad we've had this presentation tonight.
Well, Ailsa, can I just say you've just made a really important.
Yeah.
Can I just say you've made a really important point there, and I apologise if I forgot to mention it. What I really should have said is that both periodontitis and tooth decay are entirely preventable. So you're right, you can take control. That's a really important point.
Yes, but the statistics, the economic statistics and the economic statistics that you presented, absolutely mind-blowing. Who would have thought that this, these diseases could be bigger than all of the other big disease areas that we all know about? So, thank you so much for that. So we've got quite a lot of questions, Iain, so I'm going to kick straight off with the first question. This is from Kirsten Higgins on Facebook. And this is a big problem, and I don't know, you probably don't have a magic wand to wave, but he says, she says rather, I currently have no dentist as he retired. No one in my area has a place. I'm on methotrexate and worried that something will get missed. So this is a major problem that we're all aware. It's all been in the news in recent months. We don't have access to enough NHS dentists in the UK. What do people do, Iain? Especially, you know, you mentioned people in the lower socioeconomic areas and so on. What do we do?
It's a brilliant question, and it is a hugely important question. And really, the crisis we face at the moment has resulted from COVID, and I won't go into details of why. But the last government pledged a 40% increase in the numbers of training places of oral healthcare professionals, dentists and hygienists and therapists. And the current government have agreed to uphold that pledge. So it takes 5 years to train. So, and then 6 really. So that's not going to happen in the short term. It's going to take 6 years to come through the system. That was by 2030. So in fact, it's going to take longer, probably 10 years. So in the short term, what is happening is there is going to be a move to bring in, as we did with doctors and with nurses many years ago, overseas trained dentists from quality assured universities, and to put them to work in a supervised environment for a year to make sure that they're following the UK processes properly. So that's a short-term fix. In terms of Kirsten's question, yeah, methotrexate, you all know, has a lot of side effects. It can lower your white blood cell count. It can cause a sort of what we call a mucositis, which is a sort of an ulceration sometimes and a sloughing of the soft skin of the mouth. But it doesn't really associate with periodontitis, and I'm not aware of any evidence that links to mouth cancer, which is the important one, really. So I think the best thing you can do if you can't find an NHS dentist is to ask your rheumatologist to refer you, if you're concerned, to a local, the name's just dropped from my brain now, or to write to the, we used to call them the primary care trust. It's the care commissioning groups that sort of are delivering care now, and raise awareness of this. And they have a duty to provide access to oral healthcare service, and that might be through a hospital, it might be through a community setting, through a community service clinic, or they may actually have a list of NHS dentists. There's a lot of dentists are now trying to take on more NHS patients. So there is, if you like, a type of recovery starting to happen.
Yeah, maybe I'll come back to you separately after tonight and make sure we've got those details so that we can make those available for people, so they do know where to write if they want to. Maddy, sorry, I think you've got a question.
Yes, so I haven't had any submissions from young people personally, but I'd like to speak on behalf of the community and ask, is there anything in particular with regards to advice and oral health that we can give to families of young people living with JIA in particular?
Really, really important question. And because really it's very, very simple, Maddy. It's about being trained, and you do have to be trained in where the bugs are building up at the gum-tooth interface and how to effectively remove them. And those are lifetime behaviors like washing your hands and washing your face, basic healthy behaviors and anti-infectious behaviors, if you like, that really need to start at the earliest stage possible. And I always say that we should be engaging our community midwives in giving instructions, you know, when females are pregnant, because they're like sponges taking on board that knowledge and information. But the best thing you can do is when the teeth come into the mouth, is get a child's toothbrush and start brushing it for the child, so they get used to having something in their mouth and they get used to that cleaning action. You just have to be careful that they don't swallow too much toothpaste, because it can cause white flecks on the teeth. So just a pea-sized piece of a child and age-appropriate toothpaste, and it's fine. For people in their sort of the 7 to 12 age group and then into the early teens, the best advice is to try and get an appointment with a dental hygienist to be shown how to do it. Or there are some excellent resources that will show you how to do it, thinking about it. And I think, Elsa, you're going to make these available. And that's the British Society of Periodontology, the BSP, that has a website with a public and patient section to it that has videos and advice and recommendations. And there is also a European Federation of Periodontology site, an EFP site, which again, I can send you the details of, that really has some very, very really intuitive and visual material that people can access and learn if they can't access a dentist for the reasons that Ailsa mentioned earlier on.
Thank you. We will make
That's
sure
great.
that
That's really
we put this information up on the oral health area of our website. So there's a question here from Camilla de Santiago. What a lovely name. Via the NRAS website. I recently had an unexplained reaction in my mouth, all the soft tissue on the inside of my lips, like a massive ulcer explosion everywhere. Any ideas? Thanks.
Well, there are a number of possibilities. The most likely possibility would be some we call mucositis. So it depends on your medication. So some of the biologics, some of the monoclonals can cause ulceration and sloughing of the inside of the mouth, which is really quite unpleasant. That's one possibility. As we said, methotrexate can cause mouth ulcers. Another possibility is if you're run down or your white blood cell count is low, then it may just have been a herpes infection. People cringe when you say herpes. Everybody who is listening to this, including me and everybody on this call, carries the herpes virus in their brain. You get it from your mother at the age when you're born, but I'm talking about the herpes simplex virus 1, and it lives in the brain, and it doesn't cause problems unless you're run down. And then it will travel down a nerve in the mouth and cause cold sores. Some people get cold sores when they get tissue damage. And it can also, if you're very run down, you can get a little bit like with shingles, you can get a sort of a secondary infection from that virus that lives in your body. So that's a possibility, but you would have had a temperature as well at the same time. And then the third possibility is a drug reaction or a reaction to the body fighting off a herpes infection. And it's a weird condition, very rare condition called erythema multiforme, and your lips become a bit crusted sometimes. You get bleeding of the lips as well. That remits on its own in about 10 days. It sort of settles down on its own. So it could be, they're the three most likely causes. I'm just seeing actually as there's some questions on the private chat. Should I answer a couple of those, or do you want to continue with your?
Well, let's. We have got some these people who have pre-submitted questions, so let's. If hopefully, if we get time, we'll get to the ones that are coming in. I appreciate that we don't always get time to answer all the questions that are coming in, sadly. Maddy.
I've got a question from Iain via the NRAS website, and it says, can I get dental implants? I stopped hyaluronic acid 4 years ago. If not, what are the alternative recommendations? I can't use dentures.
Yeah, good question. So there's a lot of people out there putting implants into people's mouths, and the people don't need implants. There are better alternatives like sticky bridges and those types of things. If you've lost a lot of teeth and you struggle to wear dentures, then implants are a good solution in that situation. But I would be very careful about just accepting that you need dental implants. The failure rates of dental implants now are 22%. So 22% of people who have dental implants, and they pay thousands for them, have a failing implant in their mouth somewhere. If you have been taking a bisphosphonate like hyaluronic acid, for example, it does make the bone less vascular. But at the moment, there's no evidence in the scientific literature that implants are less likely to work in people who have had bisphosphonates. There are other risks with the bisphosphonates that we can probably come on to later to talk about them. So it's not a no, but for me, it would be a last resort, because there are risks of having implants put into the bone if you've had hyaluronic acid or similar bisphosphonate drugs. They're very low, the risks, very low, but there are nevertheless risks.
Thank you. A question here from Anita via Instagram. Is TMJ common with RA, and what can I do to help with it? Can you just explain TMJ for us?
Sure. So the TMJ is the temporomandibular joint. So the bottom jaw is like a bucket handle. If you put your fingers in front of your ear and you open and close your jaw, you'll feel it moving. So it's quite high up, just in front of your ears, the joint. So yeah, if you just press your fingers flat against and open and close, you'll feel the muscles in the jaw. Yeah, so that's where it sits. Now, the jaws and the teeth are quite unique. Because you need teeth to eat and live and survive, human beings have developed evolutionarily to protect the teeth above any other bone in the body. So the last place you will lose mineral from is the teeth. And it's similar actually with the jaws. We do see bone loss in the jaws, particularly with osteoporosis and osteopenia, but it generally isn't that dramatic. And when it comes to inflammatory disease of the joints, the jaw joints tend to be preserved. So I would say if you have RA and you do have joint pains, it's worth getting it checked out because it's more likely to be due to tooth clenching or grinding of your teeth when you're asleep at night. And that is very easily remedied with a special splint or a mouth guard that can be made. And many people have those. So the most likely cause is tooth clenching or tooth grinding. But you can have the jaw joints x-rayed. And the x-rays will show if there is any arthritic change in those joints if you're worried about that. It's unlikely, it's quite rare, not impossible, but I think there would be other causes of it, like the tooth clenching first.
Maddy.
Great, thank you. I've got a question from Hazel Sargent on Facebook. It says, I have been informed that there is a downside to having received osteoporosis treatment when dental treatment is needed. Would you please explain the seriousness of this, as I've been told my risk is 2%, which doesn't sound very high, or is it?
Great question. So, so when it comes to the drugs that are used, the drugs you talk about, these bisphosphonates, like andronic acid, they can be given by mouth, or they can be given directly into a vein. And what they do is they cause increased mineralization, that's their purpose, of the jaws. Or of bones in general. But if the jaw bones mineralize, that is at the expense of blood supply. And so if the blood supply gets worse to the jaws, then sometimes the skin, we call it mucosa, that overlies that jawbone loses its blood supply and it breaks down and forms an ulcer and the jawbone becomes exposed. Okay, that is called chemonecrosis of the jaws, or MRONJ is some of the medication-induced osteonecrosis. So the risks are low. I think the latest statistics are something like, it's a daft way of publishing it. It's about 1 in 100,000 person years. Well, what the hell does that mean? 1 in 100,000 person years. I think if you work it out, it's around about 0.6 to 1% chance. If, however, you've been on the drugs for more than 4 years, then the risk goes up to about 1.6%, which is probably the 2% figure that Hazel's talking about. So it is a very low risk. Nevertheless, if you get it, it's really difficult to treat, because if there's no blood supply, you can't do surgery to try and put that skin back because there's no blood supply, and the surgery won't work very well. So it's one of those things you have to weigh up and balance, a 1.5 to 2% risk if you've had those drugs for over 4 years. And ultimately, it's just best to take advice on it from your doctor or from your dentist. The oral healthcare team are very well informed on that particular side effect.
Thank you. So next question from Jan via the NRAS website. Is there anything I can do to prevent receding gums?
If I was going to give a very glib answer to that one, it would be brush harder, which is completely counterintuitive, isn't it? Mm. And let me explain what I mean by that. So there are different causes of receding gums. The most common cause of receding gums is with time through slow trauma from toothbrushing. When I say over time, I'm talking 10, 15, 20, 30 years. People who get gum recession because they're cleaning too vigorously think that it's a bad thing and they're going to lose their teeth. Not at all. It is self-limiting, and it will stop after a few millimeters. And by overbrushing, they're getting rid of the bacteria that would cause periodontitis. And therefore, the deeper seated bone loss is not happening because they're being so fastidious. It's a side effect of the brushing in a way. And some people suffer more than others because their gums are naturally thin. We call it a thin biotype. So the gum itself is incredibly thin, almost translucent. And so they're particularly susceptible to the gums receding. Now, there's a health warning here, and that is that gums can recede because you have undiagnosed and untreated periodontitis. And I showed you some of those pictures. So I think the best thing you can do if your gums are receding is try and get them checked out. Ask the question, is this gum disease, or is it just, the recession that happens with time, the gum recession that happens with time? And if it's the latter, don't worry about it. If it's the former, then you need to get the gum disease treated to stabilize that condition.
Thank you. Maddy.
A question from Anne Stillman on Facebook. Is it still recommended to have antibiotics before dental treatment when you have joint replacements to avoid the risk of infection?
Oh, I'm glad you asked that. Absolutely not. And it never was recommended. It was only recommended by orthopedic surgeons. There's no evidence for it whatsoever. There never has been. There's bucket loads of research being done on it. And the reason for that is that even if you have gum disease, when those bacteria get into your bloodstream, the immune system clears them very quickly. So the risks of antibiotic resistance from having antibiotics before orthopedic surgery are far, far greater. And so the best thing you can do if you're going to have any kind of hip replacement or joint surgery is get your mouth checked. If there is any disease there, get it treated, and then just go ahead and have the surgery, but don't have the antibiotics. We even went through a period a few years ago of patients who had heart valves and patients who'd had a very serious life-threatening heart infection called endocarditis, infective endocarditis. That can be caused by bugs in the mouth getting into the bloodstream. We went through a phase of stopping the use of antibiotics before gum cleaning that is introducing those bugs into the bloodstream. We stop that now and we give that cover, that antibiotic cover, but only in a very, very limited number of cases do we do that. And that's really for people who've had a very serious heart condition or for people with false heart valves. We don't really do it in any other situation, and definitely not for orthopedic surgery.
Can I just ask a follow-on question? Well, but what about dental treatment? So if you're going to have a tooth out, for example, because I remember I had to have a tooth out last year, and I remember my consultant saying it's a dirty procedure because of all the bugs in the mouth, and I had to be on antibiotics for that. Was that not necessary?
No, you shouldn't have been. I mean, your consultant's right in that it is a dirty procedure, but if you're having a tooth taken out, you are removing the dirt. And if you think about it, if you didn't have the tooth taken out, that dirt, the bacteria are getting pumped into the bloodstream every time you eat, every time you chew, etc. That's a far greater risk. So absolutely not. I mean, it's great that your consultant recognised the complexity of the oral microbiome and the risks. I think that's really important. But actually, you didn't need to have the antibiotic to have that tooth taken out.
Interesting, thank you. So I think the next question we have actually covered already, and what we've talked about, which is the bisphosphonate related jaw issues and osteonecrosis. That one we've pretty much covered. A question, anonymous question. In 2022, I nearly died from a complex emphysema, lung collapse. Is it emphysema?
It would be an empyema, which is a lung abscess.
Empyema. Right, yes, sorry. Learning things every day. Lung collapse and pneumonia. A germ got in when I had a root canal treatment. My rheumatology, my respiratory consultant said oral health matters, which we are learning tonight. Any comment on that?
Yeah, it's not correct, and it is correct. So let me explain. So a root canal is not going to give rise to pneumonia. However, if patients go into hospital for any procedure and they have a lot of bacteria on the teeth and they have gum disease, the lung bacteria, the pneumococcus that causes pneumonia, can live in that plaque on the teeth, and quite often can get into the bloodstream, and it can cause problems that way. But I said quite often, that's wrong. Rarely it can do that. More likely what happens is that you get what's called an aspiration pneumonia. In other words, if you're in a hospital and you're ventilated or not able to brush your teeth properly, as the bugs build up, you inhale them by accident, and the inhaled bugs get into the lungs, and they can cause what's called an aspiration pneumonia. Now, if it was an oral bacteria inside the empyema, an empyema is just a big lung abscess. Again, I think it's highly unlikely that came from the root canal. It is far more likely that it's come from the gums and from some gum disease. I'm not aware ever of a root canal infection causing an empyema, but it's not impossible, but it's unlikely, because the bugs have to get into the lung itself, either directly, and that's not going to happen through a root canal, or through the bloodstream. And the most likely connection to the bloodstream and the mouth is the gums, not the root canal.
Thank you. Maddy, do you want to choose a last question? I think we've got time for one last question each.
Yes. I thought this was a really interesting question. It is anonymous. How aware are UK rheumatologists of the role of bacteria in the gut end-to-end, crossing the endothelium to trigger RA flares, and what not to do?
Great question. I suspect they're very aware, and rheumatologists are extremely bright people, and they specialise in the immune system, and the immune system is there to fight against infection. So I suspect they are. But having said that, the leaky gut that we now know is present in inflammatory bowel diseases, for example. We're learning more and more about that, and I suspect not every rheumatologist is aware that that is a risk. But it's exactly the same process that I showed you in the gums. And those ulcers can let the bugs into the bloodstream, and that can cause problems. But I'd be surprised if most rheumatologists weren't aware of that. It's getting absolute proof that sometimes is quite difficult to get, and most physicians will not want to tell you something unless they're pretty convinced that the proof is there, which is understandable.
Thank you. So one last one from me, which I think is probably a good one to wrap up on. So are you saying that dental checkups are as important as my other appointments connected to RA, such as podiatry and occupational health?
Yeah, they're at least as important, if not more important, because podiatry and occupational health will not introduce bugs into your bloodstream and fire off your immune system. And particularly if you have rheumatoid arthritis. I'll never forget one patient who'd been stable with her RA for about 5 years. She had some bad gum disease that she wanted treating. We treated it quickly and efficiently, and she got a flare of her rheumatoid arthritis, only for a week, fortunately, and it then calmed down and has been stable ever since. But I'm fairly sure that flare was because of the bugs being introduced into the bloodstream and just firing off some inflammation. Because the treatment will temporarily introduce bugs into the bloodstream. Nothing you can do about it. You still need to have the disease treated. So that's a really good point. But yes, the checkups are there for a reason, and they're there for prevention. You don't want to develop gum disease if you have rheumatoid arthritis. It could make it worse.
Thank you. We'll just take one, if everyone can bear with us for a moment, we'll just take one question that's come via Facebook Live this evening from Amanda Harness. And I think this is an important one because it's something that I think a lot of us suffer from. What is the best medication for dry mouth? I found pastils don't help, but sprays have causes and dental issues. what can we do for dry mouth?
So sadly, most of the treatments for dry mouth are very transient. So there are a number of formulations like saliva or Thana. There used to be one called Glandazane as well that are sprays, and they produce a moisturizing effect on the mouth. It's fairly transient. We in Birmingham so I'm biased here, but we have developed a spray actually for a skin blistering condition and to keep the mouth moist. It's called Norzite, Norzite. It's expensive, so I'm not recommending you do it right away, because you can actually buy it online. Better to get it on prescription if you can. And the Norzite actually, when you spray it onto the soft tissues of the mouth, it forms a layer and it sticks to the skin of the mouth. So the moisturizing effect hangs around for a lot longer. We mainly use it for people that have ulcerative disease of the mouth. So patients with skin blistering conditions, for example, is what we developed it for. So, those are probably the most common one would be the saliva or Thana. And I think it doesn't have sugar in it, I'm pretty sure. And then the Norzite is something that we are about to do a formal research trial on. The feedback from our patients is that they love it, so we're about to try and do a formal research trial on it. But it is available on Amazon, but it's not cheap, so I'm not saying go out and buy it. Okay. There are alternatives. And the Salivix pastils generally are what most people find works. It's a shame that Amanda is not finding that works, because it stimulates the saliva from the little minor glands in the lips, insides of the lips, and that releases a very thin liquid saliva that is far more moisturizing when you use it. But those are the best things we really have at the moment. And if we want to keep Joanne Cousins in the frame, how do you stop periodontal disease getting worse? Basically, really good oral hygiene and toothbrushing, to seek advice on how to do that. In the methods, actually, Elsa and Maddy, that we've mentioned earlier on, those web links to the VSP and the EFP.
Well, thank you so much. We're 2 minutes past 8, so we need to wrap up. But huge thanks, Iain. That has been a really, truly amazing presentation tonight. I've learned a huge amount. And thank you to my co-host, Maddy. It's been really interesting, and I'm sure that we'll get a lot of people looking at this after the event who perhaps weren't able to join us live this evening. So thank you to you both. Very much appreciate your time. Coming up in August, we don't have an NRAS live because it's holiday season. In September, at the end of September, on the last Wednesday, we are going to be talking to the REN Project. This is another charity that we work closely with, and they provide counsellors for people with inflammatory autoimmune disease. So we'll be hearing about the work that they do and how they can support people. In October, Maddy and I are going to be joining forces again, and we're going to be doing all things related to eyes and eye disease. So I'm sure that will be another interesting session. And then in November, Stuart, our COO, is going to be doing something for men, because of course, being November, that's generally when things happen with growing moustaches and all sorts of things like that. And just to make you aware, it is RA Awareness Week in September from the 16th to the 22nd. Our theme this year is hidden illness and symptoms, and we're going to have a symptom checker on the website. So please do watch the website for everything related to RA Awareness Week. And thank you very much for tuning in tonight. Thank you again to Iain and to Maddy. Very good night to you all, and we'll see you next time. Good night.